Good evening, everyone. My name is Madhusudhan. I'm linking in from the UK, so it's about 9 o'clock, 10 o'clock here. We are very cold. It's 6 degrees here, and I can see you all sitting in a warm auditorium, going through an excellent seminar. And I was kind of sitting through the last two lectures. Really enjoyed those two presentations. So, yeah, I would like to thank Dr. Annapurna and Dr. Aruna Corley-Merland for asking me to do this presentation. And the topic that I've been given is mechanisms of resistance to PARP inhibitors in high-grade serous ovarian cancers, and what are the translational emerging synthetic lethality opportunities for this morning's session. Okay, so introduction. What I would do is, we got a number of slides here, and I got about 25 minutes or so to run through my slides. So what I'll do is I'll give you an overview of what is synthetic lethality. Many of you would be very familiar with this. There is a link, there is a very popular link between BRCA and PARP1, so we'll have a brief overview of that. And it's always important to understand what's the mechanisms of action of PARP inhibitors, what are the current treatment algorithms, and then think about mechanisms of resistance to PARP inhibitors that we are seeing in clinic these days. Most of us who are giving PARP maintenance resistance is a big clinical challenge. So understanding what are the potential preclinical mechanisms of resistance, what are the clinical mechanisms of resistance that have been discussed in various clinical trials would be helpful. And from our own center, I direct the NASCO Ovarian Cancer Research Center here at the Biodiscovery Institute. I'll probably share some interesting preclinical work that we have been doing, investigating additional synthetic lethality targets in ovarian cancer. Okay. So what is synthetic lethality? So if there are two proteins and they are linked with each other and the proteins are functional, the cell survives. If, for example, one of the proteins is not functioning, but the other protein compensates for this, then the cells continue to survive. If protein B does not function, whereas protein A is able to compensate for it, the cell survives. But if you have a situation where protein A is non-functional, and you have a pharmacological inhibitor for protein B, and in that situation, the cell just cannot handle the damage that has been done to it, and it initiates programmed cell death and goes into apoptosis. So this essentially is the synthetic lethality interactions that can exist between genes. And these synthetic lethality interactions between genes have been described more than 100 years ago. It's not a new concept. But what is new is that over the last 15-20 years, we have increasingly understood that there is a synthetic lethality interaction between BRCA gene and PARP genes. Okay? So if BRCA1 and 2 is proficient, and if the PARP enzymes are proficient, the cell continues to survive. If you have somebody who's got a germline mutation in BRCA1 or BRCA2, and then develops an epigenetic modification leading to loss of both of the alleles, then that promotes cancer. And we also know that patients who harbor BRCA1 or BRCA2 germline mutations have a considerably higher risk of ovarian cancer pathogenesis. But if you do have a BRCA germline mutation, but you have functional PARP, then the PARP is a key DNA repair protein and it's able to compensate to some extent the loss of BRCA1 and the cells can continue to survive. Or if you have a situation where you are blocking PARP or the PARP is not there in the cells, BRCA can compensate for this and the cells can continue to survive. But you have a situation where there is a germline mutation in BRCA, and then you're using a PARP inhibitor, for example, to block the enzymatic function of PARP, and also the concept of what's called PARP trapping, which we will see in subsequent slides. So in that situation, BRCA is not functional, PARP is not functional. So in that situation leads to accumulation of DNA damages, and that promotes synthetic lethality. So this concept of BRCA and PARP was initially noted by Alan Ashworth and Thomas Halliday in 2005, and since then there's been a rapid evolution of research in this area leading up to several PARP inhibitors that we have in clinic. So the PARP genes, let's have a very brief bird's eye view of what BRCA genes do. BRCA1 and BRCA2, they're proteins that facilitate repair of double-strand breaks. And if your genome has double-strand breaks, they are lethal. They can be deleterious to the cancer cells and normal cells. But the cells have evolved DNA repair mechanisms. One of which is called homologous recombination. So BRCA1 and BRCA2 are key proteins involved in homologous recombination. If cells lack BRCA and are deficient in homologous recombination, and what the cells then do is they switch on error-prone DNA repair pathways such as non-homologous end joining, which is what leads to mutation. So the fact that BRCA germline mutation leads to cancer is because of this, that error-prone non-homologous end joining pathways are activated. So that leads to chromosomal instability, oncogenic activation, tumor suppressor deletions, and so on, and that eventually leads to a phenotype that we call cancer. Now, PARP, poly-ADP ribose polymerase, and that's a huge family of enzymes. More PARPs are being described every year. But the one that is more important in DNA repair is PARP1. It's a key player in single-strand break repair, which is a sub-pathway of what we call as basic switching. So when you have a single-strand break, it activates PARP, and then PARP then coordinates the single-strand break repair. So there is a happy marriage that exists between BRCA and PARP. So when you have a single-strand break, PARP gets activated, and then it produces PAR polymers. It pars itself, autoparylation as it's called, or it can add on PAR polymers to other DNA repair factors that can get into the DNA and then complete the DNA repair process. So PARP is essential for coordination of DNA repair. What happens when you have a PARP inhibitor? So let's look at this slide on the right side. So if you have a PARP inhibitor, the polymerase function of PARP is lost so that the single-strand break repair is lost. So that's one mechanism. Okay? So that leads to accumulation of DNA damages when you treat cells with PARP inhibitors. The second, probably more important mechanism of how these PARP inhibitors work is they trap PARP. So they are like topoisomerase inhibitors. They trap the enzyme onto the DNA. So PARP1 trapping is a key mechanism by which these inhibitors work. So when you have these kind of cross-links in the DNA, when the cells goes through replication, they can't process this, and that eventually leads to double-strand breaks. Okay? So we have the double-strand breaks here. So now we understand that there is a double-strand break that can be induced by PARP inhibitors when the cells go through replication. But if the cells have proficient homologous recombination machinery, they can process this happily, the double-strand breaks, and the cells can continue to survive. But if the homologous recombination is deficient, such as in a situations like BRCA1 mutation or a BRCA2 mutation, the cells just can't handle this double-strand breaks. And that initiates programmed cell death because the double-strand breaks accumulate, and the accumulation of double-strand breaks eventually leads to cell death. So this is how the synthetic lethality operates between PARP inhibitors in the context of BRCA germline mutations. So one of the things that we really need to understand when we use PARP inhibitors in the clinic is different PARP inhibitors have different capacities to block the polymerase activity, but more importantly, to trap the PARP1 onto the DNA. This PARP trapping potency varies across various PARP inhibitors. The highest PARP trapping efficiency is with talazoparib, followed by niraparib, then rucaparib, then olaparib, and then veliparib. So it's interesting to understand the potency of PARP trapping. That probably explains how potent these inhibitors can be in the clinic. The other concept that we need to understand when we think about PARP inhibitors in the clinic is the role of PARPs in replication fork progression, and the fact that PARP inhibitors trap PARP onto the replication forks that leads to stalling of replication fork. This is a key event. Okay? It's the stalling of the replication fork that eventually leads to double-strand break accumulations and synthetic lethality. So I hope this slide summarizes the background to what is PARP, what are the PARP inhibitors. So if you look at PARPs, and again, the PARP enzymes are not new to biology. They were first discovered in 1966. Many of us were not even born at that point. 1966. As I said, 2005 is when the seminal paper comes from Alan Ashworth, David Lord, and Thomas Halliday's group. And then there is a flurry of activity in clinical trials. We were all, I remember doing all these trials here in Nottingham, olaparib trials. So 2009, the first human clinical trial of PARP inhibitor olaparib shows synthetic lethality in BRCA1 and BRCA2 mutations. 2014, PARP inhibitor is approved by the FDA and EMA, and that's less than 10 years, which is quite revolutionary in cancer development. 2016, a second PARP inhibitor gets approved for second-line in ovarian cancer, rucaparib. 2017, niraparib gets approval as a PARP inhibitor in maintenance therapy in ovarian cancer. 2018, talazoparib is the fourth PARP inhibitor that gets approved in breast cancer. 2022, there is the PARP1 specific inhibitor that is being trialed by AstraZeneca. 2024, many of us will be aware of all these clinical trials where rucaparib now moves into first line. Previously, it was available in recurrence. Now it's moved into first line. So from 2005 to 2024, you've just seen a flurry of activity with various PARP inhibitors that have come into the clinic. Now, these drugs are not specific. We need to be very mindful of that. Many of these drugs, olaparib, niraparib, rucaparib, talazoparib, they're not specific for PARP1. They predominantly block PARP1 and PARP2. And some of them also block other PARPs. Again, as clinicians, we need to be very mindful of this. It is the blockage of PARP2 that leads to hematological toxicity in patients. So many of us will be familiar. For those of us we prescribe niraparib to our patients, the first 8 weeks, they're all having thrombocytopenia, anemia, and so on. And we are almost, we are monitoring their full blood counts on a weekly basis. And based on their numbers, we are trying to dose reduce niraparib so that the toxicity is manageable. And that's primarily driven by these PARP inhibitors blocking PARP2. And that is why there is a huge move to develop PARP1 specific inhibitors. In our own laboratories, we have biotech collaborative research that is going on developing PARP1 specific inhibitors. And the hope there is that we will be able to avoid the hematological toxicities that we are seeing with many of these mainstream PARP inhibitors that we have in the clinic. So remember PARP1 and PARP2. And then, of course, there is the concept of homologous recombination deficiency that I'm sure most of us here in this audience would be familiar with. That is to predict in whom will PARP inhibitors be suitable. Yeah. So they need to have deficiency in the homologous recombination pathway, which, as we discussed, is a key mechanism involved in the repair of double-strand breaks. So there are many homologous recombination genes. The primary genes that, for example, in the NHS Genomic Medicine Service, we have a test called R208 that looks at if you have a particular family history or risk of breast cancer or all ovarian cancer, for example, will get investigated for homologous recombination genes, germline mutations. That's the R208. That's at the germline. And in the somatic tumors, you can do somatic HRD testing, homologous recombination deficiency testing. And there are quite a few tests that are available out there. The most popular one is the Foundation Genomic Instability Test that looks at loss of heterozygosity, telomeric allelic imbalances, and large-scale state transitions. These three together gives you a HRD score, and anything equal to or more than 42 is defined as a HRD deficiency. So this is mainstream now, the Foundation test, that all patients who have ovarian cancer, when they have the initial surgery, they will get their HRD testing done, and all ovarian cancer patients will have a germline BRCA testing done, along with PAL2, ATM, CHEK2, and others. So this has really changed the therapeutic landscape for stage 3 and beyond ovarian cancers. So, and again, a point to remember is 50% of ovarian tumors have HRD. Yeah, and that's quite common. Yeah. So here I've given you the ESMO clinical practice guidelines, and again, most of us will be very familiar. The newly diagnosed epithelial ovarian cancer patients and those that have recurrent epithelial ovarian cancer patients, and that there is a pathway that we go through, largely dependent on whether they carry a germline BRCA mutation or whether they have a HRD phenotype. So that dictates what type of treatment you're going to be doing, whether PARP inhibitor maintenance is recommended or not, whether you choose olaparib or niraparib, rucaparib, PARP inhibitors, largely is dictated by what these phenotypes are. And then, of course, we heard about platinum resistance, which also influences what other systemic treatments that that we are going to be using. So I don't want to go into the details of the ESMO guidelines. Most of us would be very familiar with this. But the bottom line is, PARP inhibitor maintenance therapy, be it in first line or at recurrence, is practice changing for all of us. It's a paradigm shift with regards to how we manage these patients. The progression-free survival is substantially better. But I am yet to see a PARP inhibitor that can actually give an overall survival benefit. And there may be multiple reasons why. For example, niraparib, the recent data that was presented a few months ago, the niraparib trials, of course, they have progression-free survival benefit, but they don't translate into overall survival because of crossovers and so on. So there are multiple reasons for this. Nevertheless, that improvement in progression-free survivals by PARP inhibitors is a phenomenal change in ovarian cancer therapeutics. That progression-free survival can range from 8 to 10 months and beyond, depending on the type of, whether it is a germline mutation or whether it is a HRD. But still, it's a substantial benefits for our patients who can carry on with their lives. Their quality of life is fantastic when they are on PARP inhibitors. But the sad fact is most patients will progress after several months of PARP inhibitors. That's a fact. And we face this in our clinics every week. So then the question that arises is there a clinical test to detect the emergence of resistance? Can we, for example, pick up these resistant phenotypes a few months before there is a radiological or a clinical progression? The answer is we don't have it at this point of time. But the view is within the next couple of years, we are heading in that direction that we might have these kind of tests which will be incorporated into clinical trials to answer those questions. The next point, is there any synthetic lethality application in the clinic beyond PARP inhibitors? Not yet, but over the next 2 to 3 years, we are going to see a flurry of clinical trial evidences that are being presented, which will move this field forwards as to what do we do beyond PARP maintenance. Okay? So why is this a problem? Because as I told you, patients have the PARP inhibitors for several months, but unfortunately the cancer progresses. And preclinically, a number of research studies, including from our own research groups here based in Nottingham, we are seeing certain patterns that are emerging with regards to what are the preclinical mechanisms of resistance to PARP inhibitors. So let me very briefly take through this. So as I told you before, 50% of tumors are HRD, they are homologous recombination deficient. So it is in these tumors that you actually use PARP inhibitors, which leads to double-strand break accumulation and cell death. So not surprisingly, cancer cells are always cleverer than us, and they always find mechanisms to bypass the HRD. So the key routes to resistance, in at least in the preclinical setting, is restoration of homologous recombination. And that restoration of homologous recombination can take multiple routes. It can be a reversal mutation of the BRCA1 and BRCA2. It can be PARG mutations, or it can be stabilization of the replication fork, or it could be the overexpression of what we call as Pol theta or Pol Q, which is important, and I'll come to it in a minute. Loss of other complexes like shielding complex, overexpression of CDK12, V1, and so on. So there are multiple mechanisms, but probably from a therapeutics point of view, if we can think about restoration of homologous recombination, stabilization of replication fork, and upregulation of Pol Q. So that's probably is a key. And in the HR restoration, reversion mutation of BRCA1 and BRCA2. So those are some of the key processes that we are seeing preclinically, but are also having relevance in the clinical setting. My group publishes quite a lot in this area, so I might recommend two or three recent articles that folks have written looking at this problem of PARP resistance. So restoration of homologous recombination as a mechanism of PARP inhibitor resistance is a big deal in ovarian cancer therapeutics. And if you follow up your tumors over a period of time, at least 20% of these tumors will reverse their BRCA. They may have a BRCA1 mutation and silencing of the other gene to start with, but eventually the tumors evolve when they are exposed to PARP inhibitors, that there's some clones will actually develop frame shift mutations that can restore the function of BRCA or RAD51. Now that's a very interesting mechanism by which ovarian cancer cells can develop resistance. The other one is, as I told you before, you can have a germline mutation, but the other allele can get promoter hypermethylate. And the cells can evolve mechanisms by which they hypomethylate and then re-express the BRCA. That way they restore homologous recombination function. And then there are other complex pathways such as those that involve REV and SHIELD and other pathways. Loss of REV1, 53BP1 are also involved at least in preclinical studies. But this one here, BRCA frameshift mutation and hypomethylation of BRCA seems to be clinically relevant. The other aspect that I spoke about is replication fork stability. And if I can remind you, so PARP inhibitors trap PARP onto the DNA. And during replication, if that happens, the replication fork does not progress. That leads to replication stress. And the replication stress leads to various biochemical processes that can either repair the replication stress or the cells are frozen at that point that leads to double-strand break. So those are the two things that can happen. So this replication fork stability and the mechanisms involved there can actually influence PARP inhibitor resistance. So say, for example, there is a factor called SLFN11, and if you are deficient in SLFN11, for example, there is reduced toxic double-strand break gaps despite PARP trapping. Okay, so that's one of the mechanisms of resistance to PARP inhibitor. So what I want you to kind of think about and look at this process is, whenever there is a replication fork progression or whenever there is a replication stress, one of the first things that happens is there is a protein called replication protein A, which is the founding protein that recognizes DNA damage in cells. It coats any place where there is a DNA damage. Replication protein A will coat the DNA and then start the DNA repair process. So replication protein A plays a critical role in coating the DNA, which initiates the DNA repair process. Just hold on to the thought. Now look at, if you have a stalled replication fork, your cells can activate additional DNA repair pathways. And how do they do that? As I told you just a minute ago, replication protein A coats this damaged DNA. And the replication protein A, through its protein interaction domains, it can attract ATRIP and ATR and other DNA repair factors, which can activate CHEK1, V1, and then lead on to G2M checkpoint progression and other DNA repair pathways. So what I'm trying to tell you here is, although you have a blockade, you can still activate bypass DNA repair machineries, largely processed through RPA interactions with ATRIP and ATR. Now, there is a new family of enzymes called PARP that process PARs, poly-ADP ribose polymerases. They are processed by these enzymes, glycohydrolysases as they call. And again, PARP or ARH deficiency recently has been identified as one of the other key routes to resistance to PARP inhibitors. PARP mutations itself, if the tumor develops PARP mutation, that itself will reduce PARP trapping. And if the PARP trapping is reduced or the polymerase activity is reduced, PARP inhibitors are not going to work. So PARP mutation is an interesting, clinically relevant concept. Then, of course, the common transporters. The drug goes into the cell, but if you have ABCB1 transporter overexpression, the olaparib can be flexed out, so there is no PARP inhibitor inside the cell to do its work. So that's another mechanism. And the last one I want to remind you is this POL-Q or POL-theta-driven resistance. And this is now clinically relevant. Okay? So what POL-theta or POL-Q does is it's involved in a process called microhomology-mediated joining. And if it's overexpressed, that is one of the key routes to resistance to PARP. So now folks have developed POL-Q inhibitors and they are going through clinical trials. And hopefully we will see some spectacular results in patients who have progressed beyond PARP inhibitors. So the current clinical scenario is this. Reversion mutation we see in about 20 to 26% patients. About 7 patients have problems with SLFN1, 12, 11. CCNE1, cyclin E amplification, overexpression is a problem in 16% of patients, certainly in the EVOLVE trial. So look at the EVOLVE trial data published in Clinical Cancer Research a couple of years ago, which prospectively monitored circulating tumor DNA in patients to understand what are the mechanisms of developments of resistance. So what is it that we are doing here in Nottingham? I have about 5 to 10 minutes to rapidly go through some slides to give you a feel of what kind of translational research work that we can do in this area. As I told you, I lead the NASCO Ovarian Cancer Research Center, which is really an interdisciplinary enterprise within the Biodiscovery Institute, which has about 800 scientists of various types, starting from drug discovery to engineering to biology and clinical academics and so on. We have the NUH Gynae Oncology Surgical Center, which does ultra-radical robotic surgeries. Then we have the NUH Cancer Center. So it really is an interdisciplinary field looking at this problem as how we can handle this problem of resistance in patients. And we have 4 themes. One is preclinical development of new synthetic lethality applications, understanding PARP inhibitor resistance with serial clinical samplings, and hopefully in about 18 months to 2 years, we will have some really interesting data to share. So what we are currently doing is our patients are coming into our clinic receiving these treatments. Of course, they have their tumor samples initially, but every 3 months we are collecting their blood samples for ctDNA, circulating tumor DNA, ascitic samples and so on for exosome analysis to try and understand how do cancers evolve by developing mutations and amplifications of various types. And then we have a focus on various clinical trials, hypertherapy, and so on. So what I want to do is share some really interesting preclinical data from the lab with regards to new synthetic lethality application. So just want to show some results. We don't have time to go through everything. A proof of concept study. Now there is a big drug discovery program that's opened up now, but I'll show you some proof of concept study on this, targeting the N-terminal domain of replication protein A that interacts with certain key DNA repair proteins, MR11, RAD9, ATRIB, P53 for precision oncology surgery. So what is the background to this? As I told you, there are various DNA damaging agents. They cause various types of DNA damage on the genome. And our cells, be it prokaryotic cells or eukaryotic cells, including mammalian cells, they have highly dedicated DNA repair processes that most of us will be aware of. But then, if the DNA repair processes are not working properly, including homologous recombination, you have these persistent DNA damages in cells. And when the cells are going through replication, that leads to replication stress. So DNA damage is a common source of replication stress. Oncogenic activation, oncogenic amplification is also a key source of replication stress because there is increased origin firing when you have oncogenic amplification. That leads to depletion of nucleotide pools. That leads to replication stress and so on. So the DNA repair, DNA damage, and replication stress are very closely related to each other. And if you look at ovarian cancer, high-grade serous, we've just heard TP53 mutation, 100% of tumors, cyclin E amplification, 20%, MYC amplification, 40%, yeah, homologous recombination deficiency, 50%. So ovarian cancer is a very fertile ground to do these kind of research. In fact, you can look at targets that can simultaneously block not only DNA repair but also replication stress. So that's what we've been looking at for some time now. Can we kill 2 birds with 1 stone? Can we target one protein so that we target replication stress as well as DNA repair at the same time? And we think replication protein A is very interesting from that perspective because it's not only involved in processing of replication forks, but it coats the DNA. Wherever there is a single strand break, replication A will coat this to prevent nucleolytic digestion and coordinate DNA repair. So we've been working on this problem. And this protein has got 3, it's a heterotrimer of 3 proteins, RPA1, RPA2, and RPA3. The RPA1 N-terminal domain is the protein interaction module, which interacts with a number of key proteins, ATRIB, which is involved in ATR-mediated DNA repair. RAD9, which is involved in V1 check1-mediated DNA repair, interacts with MR11, which is the foundation sensor of DNA damage. P53, which we all know plays a role in multiple processes. So this particular protein interaction module is highly, the structure of it is very neat. It's a very distinct pocket that can be targeted by a drug, for example. So we've done lots of target validation studies in our own homegrown tissue microarrays of over 500 or so patients, where what we see is high levels of RPA1, high levels of RPA2 is consistently associated with poor progression-free survivals and overall survivals in patients in whom we have follow-up data of at least up to 10 years. And at the transcriptional level, again, we see that RPA1, 2, and 3 are all overexpressed and have poor survival outcomes in patients. We have looked at the TCGA dataset and explored the mRNA levels and the amplifications of RPA1. And again, what we see is there is a linear correlation between the mRNA levels in ovarian tumors and gain and amplifications. And there is a clear link between the loss of RPA1 and increase in genomic instability. Then what we have done is, just to prove this, that the target is worthwhile, is develop all the siRNA CRISPR models and have cell lines that have no RPA1 and then see whether they are platinum sensitive, which they are, and that is associated with the double strand break accumulation such as through 53BP1 fluorescence or gamma H2AX fluorescence. Is associated with G2M cell cycle arrest and increased apoptosis. You can treat these RPA deficient cells with talazoparib or olaparib, and again you can see substantial increase in double-strand breaks, G2M cell cycle arrest, apoptosis, and so on. Again, giving us the initial hint that perhaps manipulating RPA may not be a crazy thing to do. But one of the key issues with these kind of drug discovery projects is RPA is an essential gene. It plays a critical role in replication. So you can't go and knock out a gene because that is going to be lethal to the cells. So you need to be thinking about mechanisms by which you can pharmacologically block certain aspects of the protein. And that is where we are now focused on, is actually looking at protein interaction domain inhibitors. So we got a cell line model where this is a BRCA deficient one, whereas this is BRCA proficient, and it is also overexpressed as MR11, RPA1. So we have a neat model where we have a cell line which is PARP resistant, PARP inhibitor resistance, overexpresses RPA1. So we've been looking at a potential small molecule that blocks the interaction between RPA1 and all the other essential protein that I've described before. And so far, the data here suggests that this particular compound, for example, is fairly cytotoxic even in a highly resistant cell line. Even at 1 micromolar, we are seeing some increased cytotoxicity, and 1 micromolar is usually a reasonable starting point to initiate drug discovery programs. So currently what we are doing is we have a nice pharmaceutical collaboration, actually doing high throughput screenings of small molecule inhibitors, and hopefully the hope here is that we will drive this new synthetic lethality application at least into a xenograft model within the next 12 to 14 months. So I'm going to conclude today's slide. I don't know whether I was on time, but the conclusions that I would want to share with you is, we all agree that PARP inhibitor maintenance has changed treatment landscapes in high-grade serous ovarian cancer. However, most patients eventually develop resistance. Clinical biomarkers of development of resistance is of course an area of unmet need. There are lots of clinical trials that are looking at this point of time. But the development of targets beyond PARP1, and particularly beyond situations where patients are resistant to PARP1, is urgently needed. Watch out the space for POLQ inhibitors, which is currently going through phase 1, phase 2 clinical trials, and I won't be surprised if it goes for a major registration phase 3 trial sometime soon. Okay. So on that note, thanks for asking me to give this presentation, and I hope I've covered what Dr. Annapurna had asked me to do. I'm happy to take any questions if we have time.
Thank you very much, Dr. Madhusudhan. As always, fantastic and very elegant work, and exciting to know everything you're doing. I remember we were working on this RPA together, and we also reported higher expression of RPA3 in about 90 tumors that we had put together for RPA as a team. So, are there any questions? Let me throw the question to the audience, to Dr. Madhusudhan.
So Aruna, just replying back to the question, so maybe we just need to go offline and touch base again on those RPA from the Shankara Cancer Foundation cohort. I think it's about 100, so isn't it?
We had the 98, yeah.
98. So let me know what the RPA1 expression data from that is.
Okay.
So let's see if it will take us somewhere. Yeah, thanks.
Okay, sure. Any questions? We never got the chance to introduce you, Dr. Madhusudhan. You kind of jumped right into the talk. So if you don't mind, I'll just introduce you to the audience. We just heard Professor Madhusudhan, Professor of Medical Oncology, Biodiscovery Institute School of Medicine, University of Nottingham, Nottingham University Hospitals. He's trained in medical oncology at Oxford, PhD in drug discovery at the Wetherill Institute of Molecular Medicine at Oxford. Currently Professor of Medical Oncology at the University of Nottingham and Nottingham University Hospitals. Clinical expertise in advanced breast, ovarian, upper GI cancers, National Chief Investigator and Principal Investigator for several clinical trials. Laboratory research focuses on translational DNA damage signaling and repair. Director of the NAS COCA Ovarian Cancer Research Center at the Biodiscovery Institute, University of Nottingham. Clinical cancer lead for the East Genomics Medicine Service Alliance, and published over 170 peer-reviewed research articles, edited 2 books, and contributed to various book chapters. It was really fantastic to hear Professor Madhusudhan. Thank you very much for being with us today and being available live to take questions as well. Thank you very much. We look forward to interacting with you again very soon.
Sure. Thank you, Aruna. Thank you, Aruna, for those kind words. But what I'm really looking forward to is if you have all those cohorts of patient samples that you have in Shankara and elsewhere, it'd be good to do some interesting work. I've been traveling all over the place to establish various international collaborations and looking at ethnic diversities of cancers, including breast, prostate, pancreas, and ovarian cancer. So we have a big cancer grant challenge funding that's come through with the US and UK groups, and we really want to establish some fruitful collaborations with Shankara and other organizations. So I would be very keen to pick this up.
Fantastic. Let us speak offline. Yeah, I look forward to that.
Yeah.
I'll write to you. Thank you very much.
Thank you, everyone. Enjoy the rest of the day. Bye.
Thank you. Oh, I had a question. Have you logged off?
No.
Okay. Since morning, we've been talking so actively about HRD and PARP inhibition, and we've had some very interactive and very exciting discussions regarding the same. What do you think of coupling immunotherapy with PARP inhibitors? Does it really happen that PARP inhibitors can increase immunogenicity? And even though a patient may develop resistance to PARP inhibitors, do you think subsequently they will be more responsive to immunotherapy?
Interesting question. That's the holy grail of ovarian cancer therapeutics at this point. As you will see, in most solid tumors, immunotherapy is mainstream. It's mainstream in all solid tumors. The only tumor that I've seen where there is yet to be a clinical application for IO is ovarian cancer therapeutics. The trials have not been great, but have been done. Whether PARP inhibitor combination with immunotherapy will lead to any substantial registration type of trials, I really do not know. I would like to be optimistic, Aruna, that something will come out of this, but there's something about the ovarian tumor microenvironment and immune infiltration and so on. Somehow the immunotherapy drugs that we have at this point just don't seem to be making any inroads. The only other thing that we have targeted agent beyond PARP inhibitors, of course, we all know is the Avastin, which we use upfront in all patients in combination with olaparib. Time will tell. I would like to be optimistic whether it will be working or not. There are ongoing clinical trials, as you know, with PARP inhibitors and immunotherapy. Let's wait and see. It's the clinical trial data that's going to be. You and me having this conversation is one thing, but clinical trial evidence is going to be the other thing. But unfortunately, we are not seeing anything promising in IO sphere for ovarian cancer. Endometrial has really opened up, as you all know. Endometrial cancer is really exciting at this point with immuno-oncology.
Yes. Thank you, Dr. Madhusudhan.
Right. Take care.